Cool. I'm going to start. So see you in a sec. Hi, good afternoon, everybody, and welcome to this webinar. We'll get started in a couple of minutes. We'll just give people time to join, sit down at the desk, find the links, all of that sort of thing. But if you're looking for AI and social care help or hype, you are in the right place for that one. People are still just trickling in, so we'll just give it another minute and then we'll make a start because we've got quite a lot of content to get through over the next hour and we want to make sure we don't overrun for anybody. Well, okay. Well, I think we'll make a start then. So hi, good afternoon, everybody. As mentioned, this is the AI in social care webinar, Help or Hype, and we're going to do a bit of a dive today into how AI is already being used in care, what the future might look like, some of the things to watch out for. I've been joined by Tommy Henderson-Ray, who's also going to talk a little bit from a social work perspective, and I will ask him to introduce himself later on in this presentation. But just as we start off, we will go through some housekeeping. So this webinar is being recorded. All attendees are on mute, and I'm afraid we can't see you. So if you want to use the chat to introduce yourself or to have a discussion, that would be fantastic. Always good to know who's here. And if you do have any questions, please do use the Q&A function, just so it means that Tommy and I don't miss anything, and we'll make sure we come back to you with answers to the questions at the end of this session. You will get access to both the recording and also to slides for this presentation as well. And there is functionality to enable captions and a transcription. So if anybody needs any of those, please do feel free to add captions to your recording. So quite a brief agenda today to whistle stop through. So my name's Katie Thorne. I'm the digital project lead at the Digital Care Hub. I'm going to talk a little bit about the history of AI and sort of some of the use cases we're seeing in care. And then we'll pass to Tommy and then have probably about 10 minutes at the end for questions. And this is part of a mini series that we have been running at the Digital Care Hub, all about AI in care. So this is episode 2 of that mini series. The first one, Care Meets Code, Defining Responsible AI in Care, was on the 10th of September. The recording can be found on our website and also on YouTube. And we have a write-up of that session, which is being published today. So we'll make sure we get links to all of you afterwards. We also then have another webinar on the 30th of September called Pledge or Perish, which is from the perspective of technology and software industry partners who have come together to develop a pledge that they will develop AI responsibly within their products, to talk about what it means to come together as a technology industry for this and sort of why they feel it's important to start looking at self-regulation and their commitments to the care sector. And then finally, at the end of October, we have a little bit of a gap because there's a care show in the middle. We want to make sure people are still able to attend. We will be doing a webinar all about green code and clean conscience, talking a lot about sort of the environmental impact of AI, what that means for care services, how you can think more sustainably about your use of technology. So all of these as well, there will be recordings made available. So if you are interested in them, even if you can't attend on the day, please do register so you'll get access to the recording links afterwards. All of these can be found on the Digital Care Hub events page. For anybody who doesn't know who we are, we provide free support to adult social care providers around technology, data protection, cybersecurity, and AI in this session as well. So without further ado, I'm going to launch into where we are for this presentation. So first of all, I'm not going to spend a lot of time defining AI. We have done that previously, and I assume most people here are fairly familiar with AI and want to know more about it. But I do think it's really important to know a bit about the history of artificial intelligence. We tend to think it's something which is very modern and very new, but the reality is AI has been around in a variety of guises since the 1950s. The term itself was actually coined at the Dartmouth Conference back in 1956, which was bringing together computer scientists and mathematicians to look at a new sort of area of computational study. This was the name that was come up with. There were no women in the room, so I don't know if there was women in the room, maybe it would have had a different name, but artificial intelligence is what we've stuck with. And then one I find quite interesting is the first ever chatbot was actually invented in 1966. It was called Eliza and was invented by a therapist and was meant to support people around their mental health when they couldn't see an in-person therapist. So these things which we are now seeing being used have in fact been around for quite a long time. Going back briefly, the one thing I should mention, the reason we've seen a sudden explosion talking about it is because of the rise of generative AI, which really has been typified by ChatGPT. It's probably the most widely known one. You also have things like Copilot, Claude, Gemini, and ChatGPT launched in 2022 and has really sort of seen such a huge rise in terms of how people are using artificial intelligence day to day. But how are care organizations using AI? So lots and lots of different ways, and I'd be really interested if there's anything that I miss on this, if people could share their own experiences and their own expertise as well. So one of the things which I think is quite interesting is we're increasingly seeing AI being used as a way of supporting staff. Particularly around things which can be a little bit more complicated for staff who work in domiciliary care or night shift workers who don't necessarily have a lot of contact and face time with line managers and sort of senior members of the team. Providing them access to a AI chatbot, which has been trained on the policies and procedures for the organization. So rather than trying to get in touch with somebody to find out how sick pay works, for example, or how many holiday days they have left, they have an app which is trained just on the organizational policies, which they can then ask that question and instantly get a response. So some of those things have been rolled out in a variety of organizations. Some are developing themselves. There are also lots of companies who are offering this now across the sector. And you get really good feedback from staff that they actually can find information at, really the typing of a question rather than having to go find their employee handbook or read through all of the policy documentation, which can be hard to find. And we're also seeing chatbots being used quite a lot from a occupancy management perspective in care homes. So when you have them on your website, so when people are getting in touch to find out if you have any space, if people want to know price lists, if you want to know what facilities you have, having a chatbot trained on all of these kind of frequently asked questions to have some of that early stage conversation with people who potentially might be interested in being in the care home or looking for somewhere for their family member can all be dealt with by a chatbot up until the point where obviously you'd have a more serious conversation or you'd schedule a visit for them to come and have a look round if you did have space. And we're seeing the same thing being used increasingly for recruitment as well, particularly for organizations who are interested in recruiting younger members of staff, so Gen Z, your 18 to 24-year-olds. They really value instant communication, and you can see quite a lot of drop off if they send in a CV or a job application and don't hear back, ideally within the next hour. Then a lot of Gen Z can really switch off from the recruitment process. They expect things to be done instantly. An hour response time, obviously not feasible for managers who are really busy or for senior staff who've got a lot of other things on their plate. So actually having an AI who can automate the response, can say thank you for sending this in, can do follow-ups for additional information if you need it, and also can schedule an interview for you, can give the person who's applying for a job that really rapid feedback without it being a huge admin burden for you, always keeping an eye on things. We are, though, obviously seeing AI being used from the other side. We're seeing a lot of people using AI to write CVs, which can actually be quite hard to spot. So when you talk to people who do a lot of recruitment, they're saying it's more and more important to have that in-person interview so you actually really know what that person is like. Um, we haven't yet seen a lot of people using AI to evaluate CVs. I think that really would be down to you as an organization and your approach. I would suggest you'd want to yourself look at CVs for potential applicants for jobs. You'd want to make sure you have time to go through it, see if that's a right fit, rather than trusting a machine to automate that process for you. But that's really for each organization to decide. We're also seeing a lot of AI being embedded within existing systems. So your existing digital social care records, rostering systems, we're seeing a huge amount of this on. I've seen in the chat, there are people from a variety of different AI software companies who also offering a lot of products. The opportunities really are endless. The things I think are quite exciting about where it can be embedded in existing systems is particularly around reports. I know I always had a huge issue when I was working at a nursing home, trying to find exactly the right number of buttons to push to find where reports were hidden in the system that I was using. I knew it was possible to have a report, for example, on every fall that had happened in the last 6 months, but it might take me a while to navigate there and to actually do all of the toggles and drop downs. So the opportunity in the future to be able to just ask AI to create me a report of all falls which have happened in the last 6 months feels like a much easier process. So if you are a care organization who is on the call and you haven't already had a conversation with your existing software suppliers about what their AI roadmap is, I would recommend that you do have a conversation with them. They definitely will have one of some site type. So make sure you're talking to them about what that would look like. I also, just as a personal note, used AI to generate all of these images, which is a thing that you can do as well if you're looking for ways to create content, potentially if you're looking at social media and that sort of thing. Image generators are getting much better. Though you will see I struggled with this particular one because it wanted to do American spelling, and so organization has a Z rather than an S, and it wouldn't change it for me, and I'm not at all bitter about it. So we also have some forms of software being used in the care sector now, which are actually regulated medical devices and have also got AI functionality within them. I'm sure many people will be aware that there is a pain check, for example, which can do pain assessments, and it uses a camera on a smartphone to be able to look at microfacial expressions on somebody's face if they are living with dementia and struggling to articulate their pain. These microfacial expressions, which are invisible to the human eye, can be picked up by the AI and can indicate if somebody is in pain. It's actually been proven through various research studies now to reduce prescription of antipsychotics for people living in dementia and also reduce polypharmacy for people living with dementia because it can more proactively support a nurse and staff team to spot pain. I will say it does not replace a care worker or a nurse at all. It's meant to be used in conjunction with it and is linked to the Abbey Pain Scale. And there's a variety of different apps out there as well, also addressing wound dressing and wound treatment and wound assessment as well for tissue viability nurses in particular, working with a lot of these systems. In care provider organizations, a lot, you also have translation as a very obvious application of AI, particularly if you're working with a lot of people who have English as a second language, or a lot of your residents or clients are people with English as a second language or potentially no English at all. The translation functionality through AI is very, very good now. For most languages, it does struggle with some of the smaller, rarer languages, but your sort of widely spoken ones is very good. And we're also seeing people use it not just for language translation, but also speech to text and text to speech, which particularly for people who've got disabilities or who may struggle with reading and writing can be a really accessible option for them. We're seeing more and more care staff who are interested in using speech to text to be able to speak their care notes about what they've been doing and have it written up in that way so they can do it while they're walking around. So all of this functionality is just more and more prevalent. And finally, I think it's worth talking about how AI can support with activities. It doesn't always have to be about direct care. It doesn't always have to be about admin efficiencies and writing summarization reports and meeting minutes. Talk a lot to working age adult services, particularly people with learning disabilities, who say about how they've been using AI with the people they support to create videos, to create games, to create imagery, also to give suggestions about potential activities and things to do in different variety of areas. So it can be actually a really like collaborative experience between care and support staff, people who are using care and support, activities coordinators. And so you do think about how you can be using these things for fun as well. But I think it is worthwhile to think about what some of the risks of this technology are. There's obviously risks to any kind of process change that we do within care. So I don't think we should be inherently anti-AI. Any kind of new technology or new change is something that we need to think about the risk for. And there's lots of ways to mitigate these risks. Um, One of the big ones, though, about a lot of generative AI in particular is it's really limited by the information that it's been trained on. It doesn't know, it doesn't think. It is trained on large data sets, generally speaking, and then it gives you outputs based on the data set it's been trained on. So that means you need to be really careful about how much you trust the system when you don't know what data it's been trained on. There have been lots of examples about how this can lead to bias, for example, lots of examples which might come onto later as well about hallucinations and what that means. But if at all possible, think about what data it will have been trained on before you trust it straight away. Similarly, generative AI is really constrained by the request made of it, so it can't know what you know. So if you are entering information into ChatGPT or to Copilot and asking it to do something for you, it's important to be really specific. It's called a prompt, what you do here. And if you are interested in getting better at this, I would recommend that you do prompt engineering classes or courses, lots of free ones online, lots of quick 5-minute YouTube videos about how to get the most out of these, but also play around. But a good example would be if you are wanting a generative AI to create a report summary for you, you could just say, create me a 100-word summary report, but that doesn't give it any boundaries about what kind of language you would like that to be in, who the audience of the report is, and it might not be in the format you would like it to be. So if you were saying, want an exec summary report for your board of directors, for example, you could say, create a 100-word summary of this report in formal British English to be presented to a board of directors. Make sure it has X, Y, Z points and follows this format. And you can give it an example, and you'll have something which is much more usable straight off the bat. I do think we need to increasingly consider where the boundary is between work undertaken by social care staff and where work is undertaken by AI. We're not yet in a position where we have AI telling care staff what to do, but we could see a future where there would be suggestions saying this is the right course of action. And what does that mean for care staff when they have to use professional judgment to potentially go along with what an AI says or to overrule it? This is something that we're already starting to see in the medical system in the US, not something we're necessarily seeing in social care here. But I do think we need to think about that balance between what an AI does and what care workers can do. And obviously, this then leads to ethical considerations for people we're supporting and for the care workers themselves. When you talk to care workers, they're quite often quite nervous about being replaced by AI. They have a lot of concerns about what it means for them when AI is being used. So it's really important to bring them along on a journey with you. And for people we support, again, very mixed attitudes towards AI. We've done quite a lot of groups and co-production groups of various working age adults and older people about AI. And have found, generally speaking, that people who already have good experiences of the social care system and have a lot of trust in the system believe that it will be used in a way, AI will be used in a way to help them. But where people already have low trust or have had bad experiences, they can be very negative about AI and technology in general because they don't necessarily feel it will support them in a way they choose. Bias is a big thing around AI that we should be looking out for. So there was a recent study from London School of Economics at their Centre of Care Evaluation and Research, which looked at real care assessments anonymized care assessments, but the details were all real within them. And then they ran them through an AI system, first with a man's name, and then secondly with a woman's name, and asked the AI to say which ones should receive funding and care packages and which ones shouldn't. And when you had exactly the same care assessment medical records with a man's name on it, it was more likely to be recommended for a funded package of care than if exactly the same information had a woman's name on it. We know these systems can be biased, but also all humans can be biased. We all have our own set of biases and we have to work to overcome them. So when you're looking at AI outputs, it's also worth checking your own biases and the potential biases of the AI. So just something to think about. Hallucinations is something which we don't really know why they happen. I think it's quite a nice word for basically the AI is lying to you. It just makes things up sometimes, and we're not quite sure why. This is an interesting one in the legal profession. We've seen quite a lot of this where lawyers have used various forms of ChatGPT Copilot to write up closing arguments, have read this out in court, and then it's made up case law, which doesn't exist, and you've had lawyers being disbarred. I mean, you could say a lawyer should know better than to just trust an AI to create closing arguments. But we need to make sure that we're looking at the sources of any of the systems that we're using. You can ask most of the generative AI systems out there to provide sources. Do then click on them to make sure that that exists. In social care in particular, we are going to see a massive rise in abuse and fakes related to AI. AI images are now incredibly good. I'm sure many of you will have heard of the case of Taylor Swift, who had people use AI to create pornographic images of her without her consent. Obviously not her, these are AI generated. But this is happening increasingly to people across the country. You don't have to be famous to potentially be a victim of this. And if you are supporting people who are already particularly at safeguarding risks and who are vulnerable, this is another vector that we need to be considering as a sector and about how we support people around this. Also, it is now very easy to take a recording of somebody's voice. Sorry, Tommy, yours and mine are both very online now, so anyone could do this to us and then use AI to generate us saying basically anything that we wanted. They can do this through a phone call, can say, call somebody, say, oh, it's your daughter, it's your granddaughter, your son, whatever. I'm in help, please send money, I need you. And it will sound exactly like them if they have a recording of it. So again, it's just another way in which people who are vulnerable could be at risk. I already touched on disempowering staff. We're hearing some staff members are very nervous about this. They're very nervous about being replaced. But also we're hearing from some staff that they're being told not to speak to their supervisors or line managers and to ask AI instead, which is obviously not brilliant for a retention and training element. I'm sure nobody who's attending this call would do this, but I think it's important to include staff in the journey. And there are some significant environmental concerns around AI. We will be doing a deep dive at the end of October into this, but I do think it's worth sort of touching on that and the amount of power and water which is used to power AI. And probably the number one question that we get at Digital Care Hub is, can we use AI to create care plans, basically? And the answer to that is it depends. We don't have specific legislation or regulation around AI necessarily yet, but we do still have the Data Protection Act and UK GDPR. If you are using most of the free open source AI systems like ChatGPT online, it is processing that data outside of the European Economic Area. You cannot put personal identifiable information into these systems. The data is being processed outside of the country. That is breaking the law. Don't put personal information, which is identifiable about either your staff or your clients, into a free AI system. Also, with large language models, it's nearly impossible to take data out of them once it is in there. So if you put somebody's medical details in, you can't then ask it to delete it necessarily. There's no proof that that will happen. So you need to be really, really careful that you are not breaching data protection legislation around these systems. It is different if you've got closed loop AI. It is different if you're using some of the paid for ones where you can check this yourselves, but don't fall foul of doing that. The CQC recently gave a care service inadequate because of their lack of governance about how they were using AI. So not the AI itself, but not having the governance around it to be using it safely and correctly. So do be careful. I've been doing a lot of work in this space, obviously with the Institute of Ethics and AI at Oxford University and Cass& Consulting and about 50 organizations from across the country and also internationally now, looking at what co-produced sort of guidance around the responsible use of AI might be. This is all available freely online. It's been developed with care workers, social workers, nurses, people who use care and support, registered managers, nominated individuals, commissioners, department technology, that sort of thing. Um, I won't go through all of it in detail now, but if you are looking for a framework to support you with how you use AI within your services or organizations, that is there. There is also a specific column for tech industry providers, and the tech pledge that I mentioned as well, which will be talked about more next week. We cover 12 domains in our guidance. I think most of these are things you would expect. So cover things like transparency, bias, data privacy, accountability around AI. I will say sustainable technologies isn't talking about environmental sustainability. There's more work that needs to be done in this space. It's more about what are the risks around working with startup companies, and how you can mitigate those and sort of the benefits of sort of some of the flexibility that you get there. But obviously, it's an emerging technology. And we also worked with a group of care provider organisations and were funded by the Digitising Social Care programme at NHS England to develop some top tips for care providers around AI. I again asked AI to turn this from like a list into something which looks a little bit better and to turn it into an infographic of our top 10 tips. And it has made it look much better, but also has duplicated always have a human review, which I thought was quite funny of it. It's not meant to be in there twice. One of those should actually be maintaining ethics, but it's deleted that to have a human review in there twice. But I think generally these are things which are worth considering. So again, this guidance exists, it's out there for you. We have a lot of resources. We will circulate slides to everybody after this call. But I want to make sure there's time for Tommy to speak. So I will pass over then to Tommy to give his perspective. Thanks so much.
Thanks, Katie. So insightful. I've got loads of notes from what you've said there. So yeah, help or hype AI masterclass. Thanks for attending. And I wanted to give you a perspective of a social worker's view on it. So I work, as Katie said, in the Digitising Social Care programme. I've been a social worker for nearly 20 years in children's social care, adult social care. Also worked for not-for-profit care providers and worked in the NHS as well. So I have a view of lots of different facets of the organisations, the NHS, and the different organisations in adult and children's social care. And as a social workers, as you well know, bridge that gap of children's social care and adult social care. So a lot of what I talk about is applicable in children's social care and adult social care, which is an equally complex lens, but it's worth bearing in mind that what we talk about here is actually kind of mirrored as debates and conversations in children's social care as it is in adult social care. So if you could move to the next slide, please, Katie. Thanks. So this is the conversation I had with Caroline, who's on the call yesterday, in fact, and this is a conversation I have with people all the time, is who's leading the conversation around this? Because if it's not us, it's someone else. And we know why we're in this game. We know why we're in adult social care, and we have values and ethics and practice that we are rooted in. And particularly as a social worker, I adhere to a code of practice and ethics that are part of my re-registration process as a social worker. So therefore, I know the technology and the AI revolution that is going on needs to fall in line with my values and codes and ethics, and therefore to a degree, you want to be able to hold technology to account to those codes of ethics. But if we're not part of that conversation, in fact, if we're not leading the conversation, then someone else is. And if that someone else might not be as altruistic as potentially ourselves. So it is really great that you're here. And the more empowered we become, the better we will be at leading that conversation. Next slide, please. And, you know, we can't get away from the fact that this concept of AI, but more broadly technology as a whole, of which artificial intelligence is just a part of, is going to reshape everything that we do from now onwards. And in fact, I would argue that the concept of care and the ability to care and the experience and feeling of care is now inextricably linked to technology to some degree or other. So for some people, their experience of care is inextricably linked to the use of technology. So in some ways, it's even increasingly harder to separate those two worlds together, that they almost converge together to the extent that it's hard to separate. So it is an inescapable fact. So we have to get up to speed as quickly as possible. Next slide, please. And in fact, getting up to speed is something that this lady who's called Mary Richmond did in 1911. So the conversation around technology has been going around for social workers since 1911. So in your role, you may have some interaction with social workers, or you may have no interaction with social workers. I'm not really sure, but I think generally social workers view care and technology as technology. But my argument is that Mary Richmond back in 1911 was advocating that social workers, would you believe, God forbid, use a telephone to talk to people, which nowadays is completely normal. But back in 1911, that was revolutionary. So even back in as far back as 1911, technology and innovation was a key part and a core tenet of what it was to be a social worker. Next slide, please. And indeed, there are, I'm really aware that not everybody is pro technology, and you can be a critique and a critic of technology, but there are people who would positively run away from it and not want to know. But actually, I would argue that some of these quotes here illustrate that the exponential growth in technology has and will continue to reshape our society, and it will be a dynamic force now and for future generations, as Amanda Taylor Beswick, an academic, has said. And equally, another great quote from 2013, so even over 10 years old now, it's that social work can get stuck a little bit in its battle between traditional social care, traditional social work values, traditional social work behaviors, and actually that fruitful innovation is for someone else and not for us, whereas actually it's for practitioners to push the boundaries of traditional practice in a constructive way to create, implement, and evaluate new ways of supporting people who struggle with life. So, in other words, technology is here. Us leading the conversation is a way of using technology for good in order to enhance the lives that the people we support. But as Katie's articulated quite clearly, being aware and knowledgeable of what is good and what is bad and the pitfalls and areas to think about and consider for you and your organization is really, really, really important. In fact, it's essential. Next slide, please, for me, Katie. And I would argue that for social workers, technology is rooted in definition. So again, if we're not leading the conversation, then who is? And whether you're a social worker or not, whether you're a registered manager, you're a carer, you're the owner of a care setting, or you work in social care in any particular guise or capacity, what about your values and ethics, and how do they connect to the technology that you use or procure or think about using? We know that technology plays a significant role in social cohesion, and artificial intelligence is part of that. So think about social media and the role and the value of that, and how does that relate to things like social justice, documenting life's challenges and well-being. They're really important themes to us, and they're really important themes to social workers. But how confident do we feel about talking about it and applying those themes through the vehicle of technology to social work practice and the organizations we work for? More often than not, I would suggest that social workers use the technology that they are given from their employer. Statistically, that would be most local authorities, is where most social workers sit, although some now in the NHS increasingly so, but still the majority of social workers fitting in either a local authority or the NHS are given the technology and they use it to their best ability, as opposed to shaping the conversation and saying, this is what we need. Could we consider procuring something like that? The decisions that are made are not necessarily made by the profession, but by the organizations that employ them. And therefore, social work practice has inevitably and almost vicariously, potentially subconsciously, been shaped by the technology we use rather than practice shaping the technology we use. So the academics call that phenomenon the electronic turn. So how we practice and how we support people is influenced by the technology rather than the other way around. I'm not sure that's a good thing if we think about who's leading the conversation. So next slide, please, for me, Katie. So why does it matter? you know, from a social worker's perspective, why does it matter? Because I have my role to play as a social worker. You have your role to play as whatever you do, and I need to get on with doing my job and supporting the people as best I can in the difficult situations I've got with a local authority that's got a very tight budget, or the NHS that's got a tight budget, and so on and so forth. You know, that narrative that occurs time and time again. Why does it matter? It matters because if we move to the next slide, social workers have a statutory responsibility, particularly in a local authority, for safeguarding, and that is a key responsibility of any local authority. And actually now we're seeing examples of artificial intelligence and technology more broadly being used in safeguarding ways and exploiting people's situation and vulnerability in a way that we haven't seen before. So we know that people are using artificial intelligence to create child abuse images at a chilling rate, to quote Sky News. That is a phenomenon that is happening over and over again as social workers entering into a situation where there are safeguarding concerns around that. How aware are social workers of the permutations, the nuances, and asking questions in such a way that would get to the bottom of the reality of the situation? Or do, through not knowing enough, you don't discover what you need to know, and ultimately the people who are likely to suffer the most from this perpetuated in that cycle? Or we now know that domestic abuse victims are not only being tracked by their perpetrators, but artificial intelligence is being used in those contexts as well. So equally dangerous, equally difficult situations. And we also know that chatbots are now being used quite regularly by local authorities around advice and guidance, particularly in relation to I'm seeking support from my local authority. I don't quite know where to go, and the telephone number's constantly engaged, or the email that I sent hasn't been answered yet. So the chatbot creation being something to support people with advice and guidance, which of course is a Care Act obligation of a local authority and of a social worker within that setting. But as Katie has said, if hallucinations are quite common, the information that is being given out might not and is not necessarily as accurate as it could be. And that is potentially a very damaging situation when we know that people who are engaging with social care in whatever capacity and at whatever stage may find that a very confusing, emotive, and challenging time in their lives. So AI is being used in very uh, different ways, and it would be naive to think that all of those are positive. Again, I go back to that initial quote. If we are not leading the conversation and aware of that, then there are significant risks that could happen on our watch that we are complicit by because we didn't know enough when we could have known more. Next slide, please, for me, Katie. And I want to link this to the broader concept of digital professionalism. So these are in the public domain. These are pictures and stories of social workers' conduct. Now, if you look at them, they are mainly to do with presence in terms of social media. And that's fine, but I would argue that you could extend the notion of that to digital professionalism in terms of the technology that we use and how technology becomes an extension of our own practice, and therefore how we use technology and whether that's producing information and products and guidance for people that is right, accurate, and reflective of a person's needs or not, and the organization we represent is equally a part of digital professionalism as much as how we conduct ourselves online, because conducting ourselves online is now as very much a case of as how we conduct ourselves face to face. So we know that um, training and understanding of online presence is poor, but I would argue that you could extend some of the concept of digital professionalism to how we use and conduct the use of artificial intelligence, particularly generative artificial intelligence, for the sector. So although not direct, I think it's quite important and quite sobering to think about the inextricable link between how we use technology and the accountability to us. Next slide, please, for me, Katie. So how is it being used? So in local authorities predominantly, and in the NHS to a less degree, it will look quite different to some of the examples that Katie's given, because often local authorities are very different, and they vary in terms of their appetite for innovation. They vary in their appetite in terms of budget, and they vary in their appetite of interest depending on who's in charge of the local authority, who the elected councillor is for adult social services, and whether the workforce are asking for information. So a digitally innovative director of adult social services is far more likely to have lots of different things around technology than someone who's skeptical. It's just the reality of the situation. So, but we know that RAS, or resource allocation systems, have been in care plans within local authority case management systems for a long time. Those provide ballpark figures for an indicative budget, or an IB as they're often called, for a person's care plan if they're requiring care from the local authority. That will use an algorithm. So in other words, based on the answers that you have provided in that care plan, those answers combined with your primary support reason, i.e. the reason that that person is requiring care and support, that will create a figure and budget for that local authority to base its initial care plan and the cost of that initial care plan per week on. So that's been happening for 20, 25, 30 years since case management systems were in place. So that is not an uncommon concept product. Secondly, you can go on the NHS AI Lab for social care, and it will talk about some of the work that myself and Katie looked at back when we worked at NHS Digital together, and the social care pathways funding work. So several local authorities were looking at predictive analytics and big data to look at how can we combine NHS secondary data with hospital discharge data, with data from care plans within local authorities, to influence public health outcomes, i.e. can we predict who is more likely to require care and support services based on various demographics and concerns, and so on and so forth, and long-term conditions. I don't think that has been massively successful, because it's not something that's happening a great deal anymore, and equally does fall into the category of pilotitis. There was money for it at the time, but there's no money since, therefore it doesn't happen anymore. But predictive analytics, again, is not an uncommon concept to have been in existence in local authorities for quite some time. And then thirdly, the zeitgeist of our time is the generative AI voice to text transcription. So there are a number of products on the market that local authorities are using for primarily supervision sessions, or for initial care act or care needs assessments, or functional needs assessments if you're an occupational therapist, where social workers or OTs will attend an assessment with phone in hand, and with consent will record assessments, um, and then those assessments will be transcribed, and the information that has been recorded will be then funneled or categorized into the pro forma that local authority has agreed with the supplier. So in terms of time saving and the cost effectiveness and efficiency, it's really good. There is a lot of positivity from the market around its use in terms of interest in innovation, and allowing softer skills of social workers to come to the fore, i.e. I'm able to look at you and have that conversation in a face-to-face human way, and I don't have to worry about notes and scribbling down or whatever, because I know that that's going to be captured. So that is something that is occurring. We don't know exactly how many local authorities in children's and adults that use that, but a significant number are piloting that um, in different settings. Equally, we know that some home care providers are going into that space as well. Okay, next slide for me, please, Katie. Thanks. But there's always caution with innovation, is there not? And the work that Katie talked about with the Oxford Institute for Ethics, and following that work, the British Association of Social Workers came up with their generative AI and social work guidance and statement based on that work. And there is a clear argument within some parts of the social work profession that there is a human right to a human assessment, and that should be my human right. And actually, do we have any evidence of any of the artificial intelligence tools that exist actually being useful? Do we have any concrete evidence that actually it's been useful and actually the impact on the people of whom the assessment is about? There is evidence about cost effectiveness and efficiency, but if I'm the person in receipt of care, I'm not particularly interested in any of those things. I'm interested in my experience. We have very, very, very little information on the effectiveness of these products. And that is a gap in the market in terms of knowing the reality of what people think and their experience of having used technology in that sense. What about consent? Consent is a really tricky one if somebody in the room does consent to and I know from example from having completed many assessments myself that if I am in a room and I gain consent from an individual and that assessment is then recorded, but then there may be another family member upstairs who hears that conversation, who then wants to chip in a very logical, normal, human way as life occurs and goes, I didn't agree with that. That wasn't the reality of the situation. That person may or may not have consented and may not consent to their voice being part of the conversation, and yet the blurring. So consent is a tricky non-binary concept in a world where we're asking, can I have your consent? No, I can't. Yes, I can. And the reality of the situation. So this is contention across the piece. We know that there's bias in large language models. We know that large language models are more likely to say that women make unwise decisions than men. We have academic evidence to prove that. We know that we have academic evidence to prove that um, impact on health for women is more likely to be termed as emotional well-being, whereas for men it's more likely to be considered views and wishes. Phrases that embed bias in large language models exist. So by using that technology and not leading the conversation, are we perpetuating the problem? And ultimately, the useful guidance from BASWA says, be aware of what you're using because you are ultimately accountable for what you use. I think that's quite a useful statement. So next slide, please, Katie, for me. And as social workers, there are professional standards that relate to technology and the use of. Now, I would imagine most social workers aren't aware of that, but when we renew our re-registration, these particular standards lie front and center to anything that Social Work England have to say about technology. So we do have to be aware of that. So next slide, please, with 44 seconds to go. Oh yeah, sorry, keep going. So what's next? So the social worker regulator, Social Work England, is formulating a artificial intelligence response. They're partly doing a literature review. I mean, there's only so many literature reviews you can do. I would rather they made a decision and had a position, because having a regulator position on this would be really interesting. What we don't know of is court cases and court documentations, because social workers spend a lot of their time in court, in legal processes, representing people in some guise or other, or the local authority that they're employed by. The veracity or content and integrity of information and case notes that may have been recorded by artificial intelligence, I don't know the extent to which those could be relied on in court. Equally, from a multidisciplinary team perspective, MDT meetings, professionals working together is a great way of working. But what we're seeing now is technology that's used by local authorities for case note transcription. If you've got colleagues in the NHS who work in a similar position, or the police who work on, say, Section 47 assessments or safeguarding assessments, police and NHS saying to local authority social workers, please don't use your technology because, as far as we're concerned, that's not safe when it hasn't gone through due process. So you have humanistically great connection and integration of people working together, but the technology that we've created, i.e. the artificial intelligence in this instance, not being considered safe by certain parties and then safe by others, means that you can't use it, and ultimately that positively affects no one. And to boil it all down is that as social workers we are charged with decision making. We are making decisions with people and sometimes on behalf of people, and that is an ethical concern. And if we are surrendering that decision to artificial intelligence to supplement or even make that decision for us, then that is a very dangerous path to tread. So it's about us leading the conversation and becoming more and more aware of what does work best in different situations as opposed to others leading the conversation for us. I'll stop there, Katie.
Great. Thank you, Tommy. I guess sort of in summary for both of us is yes, AI very much will help with some things, but there's a lot of hype around the practical realities of it, and we need to be more mindful about looking out for what that hype will be. So we do have about 10 minutes. I'm actually going to take slides down so it's you can see us both better. There's some questions. We've had some which have been coming through. Um, I think probably for both of us to answer on this one. So from Joseph, can I ask what level of understanding of risk with AI there is among practitioners? Is there a general sense of risk or opportunity? Do you want to go first, Tommy, and I can chip in afterwards?
My view would be that there's opportunity. I
Mm,
don't. We don't have lots and lots and lots of examples of where it's gone wrong. We have examples of where it's gone wrong, but you have to look for them.
mm,
There's not lots and lots of high profile cases of where it's really gone wrong that has then landed in people's consciousness a bit more. So I think people are more excited about the innovation than the risks that come with it, and I can understand that. That would be my view.
yeah, I'd say it very much depends on sort of which practitioners. So I've talked quite a lot to sort of audiences of commissioners and then also to audiences which is more care providers, sort of a registered manager to owner level nominated individual. I think generally commissioners that are using AI themselves much more frequently tend to have a lot more hands up in the room when I ask whether people are using AI at work, and I generally see a lot of the opportunities. It's changing with care providers. About 6 months ago, I'd say on average, less than a quarter of people in the room would say they were using AI. It's now over half are saying they are using AI. But I think people, and when I talk to people who are worried about the risks, it's not specific risks necessarily. It's more of a fear of they know they don't know enough about it and what the risks might be, as opposed to anything else. So that tends to be more where it comes from. I think a lot of people talk about opportunity and risk in the same breath, almost, which I find quite interesting. Um, Next question was from Kelly, who wondered how information will be synthesized for those who have multiple conditions. This came through when you were talking about transcription of case notes and that sort of thing, Tommy, so maybe related to that.
I don't quite understand the question. Say it again.
I wonder how information will be synthesized for those who have multiple conditions.
Um, well, it depends how. I mean, you can answer that in various ways. I mean, is that if in an assessment a person's displaying multiple conditions and how that information is then recorded, or if their multiple conditions mean that they have different assessments from different organizations and how that information is then synthesized, I guess. I'm not
Yeah,
sure. Either way, um, I'll go back to that point that we don't have any evidence of how people in the receipt of care who are ultimately experiencing these assessments, what they think. We don't know. We don't have it anywhere. Local
yeah,
authorities don't produce it because, well, if you've paid for a license and are going to use it, and then the assessment comes back and says it's not very good, then you're not going to not do anything about it, or you're going to you don't want you don't. It's a problem you don't want, isn't it? With all the problems you've got. So I think we just don't know. I think and that's quite a worrying position. We don't know.
I also don't know. Sorry, but we'll try and come back to you, Kelly, if we do find out. Um, so from Rajiv, for new products and offerings by AI providers, is there a standard sandbox or test bed for them to test their offerings, detect risks, and prove adherence? Uh, no, in short, there are certain things you can do if you're looking to sell into the NHS, and there are very strict procurement frameworks, and Tommy might be able to talk more about those. For a social care perspective, I mentioned, so as part of the work we've been doing on responsible use of AI for care, there is a technology supplier working group who've developed sort of a pledge, which is a series of commitments to ethical design and are working together in this space. If you'd like more information, I will make sure there is a way to contact that group in all of the notes I send out after this. But yeah, I think it's still a little bit of a open space outside of things which classify as a regulated medical device.
Yeah, spot on. It highlights the tension between technology that might overlap or spill into different sectors. So, for example, if you're using it in social care, there aren't particularly any, whether you're a local authority care provider or you're buying it yourself on a personal budget, there aren't any particular standards you have to adhere to. You can use what you see fit. Local authority will complete a DPIA, data protection impact assessment, and probably the local care provider might do the same as well. But what goes beyond that is not clear. Whereas if you wanted to use the same or a very similar product in the NHS, as you can imagine, there will be a whole myriad of things that need to be completed around data protection. You need to do a DTAC, so the digital technology assessment criteria. You probably have to do DSPT. You have to be Cyber Essentials Plus. You have to have a clinical safety officer. You have to clinical safety officer log, and so on and so forth. You probably have to be fire standard complete, but we don't have that reciprocal. We don't have that reciprocal drive in adult social care, nor do we have a body or mechanism to enforce that either, as far as I understand. So, on the one hand, you can be more innovative because you can choose what you want to do, and that might be fair enough to do so. But on the other hand, um, if you have your biggest partner, the NHS, next to you, who has very clear criteria, and the product you're using doesn't meet that criteria, then ultimately it's the people at the end of it who suffer.
Thanks, Tommy, there's a lot of questions coming through, and I appreciate we only have about 4 minutes, so we'll
It's
try
always
and
the
do,
way, isn't it?
I know, rapid fire. If we don't get to your question in this time, I will make a note of them and we'll come back to you via email as well. So don't worry, we won't just miss your question. Do we know if people receiving care are told if AI tools are being used in the planning or recording of their care?
In adult social care, local authority social worker practice, yes, because if you don't have consent, you can't use it.
Yeah, in care providers, we don't know. We personally would recommend consent needs to be happening. And also, there was a big piece of research by the Health Foundation earlier this year on attitudes to AI to be used in health and care. It was mainly around the NHS, but a lot of it is applicable. They asked people if they wanted to be told that AI was being used, and people responded yes, even if it was just generating a GP note. People would prefer to be told that AI had been involved in it. So I think we know from that attitudinal study of over 6,000 people, people want to know where AI is being used. AI transcription. AI summaries are generally very good, but the original transcript pre-AI often makes little sense. I feel your pain on that one. Would a regulator want to see these anyway and or be used in court? We're taking legal advice on this at the moment because obviously we have a duty to keep a contemporaneous record of care. When I was a care worker, I was always told that I needed to write an accurate reflection of what care I delivered. And if worse comes to worse, I had to stand up in coroner's court, for example, I could say, no, this is what I did in my own words. And then obviously if it's being rewritten, would that count as, my true and accurate reflection of the care that I delivered? We don't know, but I just thought we should probably contact a lawyer. So I don't know if you've heard any more on this one, Tommy.
No, but I anticipate with Social Work England that I'd be interested to know when it comes to fitness to practice claims or lack of fitness to practice claims, and the use of artificial intelligence as part of that. I anticipate increasingly happening until there's guidance in place.
Yeah, I would recommend keeping both at this time. Having a record of what was originally said is probably just covers you better.
Yeah, agreed.
Is there a difference between the way AI is used in care facilities to that used in hospitals? I mean,
I mean, generally, I would say yes, because artificial intelligence, in terms of a medical model of care versus a social model of care, the medical model of care, you can use artificial intelligence through MRHA Class 2 to make decisions, because there may be evidence to be able to spot conditions through a scan that artificial intelligence can do with a very high level of accuracy to say someone has condition A or condition B, and therefore pathway wise you need to do X, Y, and Z. That's the medical model of care. So yes, in saying that sense, yes, but because we're talking about social care, which is much more around context, situation, there are different moving parts, and that makes it much less qualitative and more quantitative in its nature, doesn't it? Qualitative, not quantitative, sorry, the way around.
thanks, Tommy. And finally, I actually don't know the answer to this one. So any specific Copilot agents under development for use in social care in the UK?
I think
Um,
Copilot view themselves as being for everyone.
yeah, so I would be astonished if there
Yeah.
aren't agents being developed. I'm not aware specifically. The LGA Partners in Care and Health have an AI hub where they are keeping case studies of local authority AI pilots which are taking place. I would look there in the first instance. We will share a link. But it's a good question, actually, and something I'm going to go do some digging on because surely that seems like the best use of Copilot right now. Great. That does wrap up all of the questions somehow, just on 2 o'clock still. So thank you very much to everybody who has joined today. And there's some notes from Eleanor about recording and slides being sent out. Tommy, thank you so much for joining us today and for giving such an in-depth presentation. I hope this has been useful for everybody. Bye.